Hello, everybody. Hi, Carolyn. Twice in one day. I started the morning. Wasn't it this morning? Was it just this morning? It feels like it was maybe a day ago.
It was this morning. It's very nice of you to do that, and I hope it's not just a burden.
Not at all. Not at all. It's good to think with you about that stuff, and we'll circle back. The AHP BHI team will circle back with you with some thoughts.
Sounds good.
Great. Hey, everybody else. Yeah. Renee, I'm letting you know now. You don't have to show your screen. I know you're there. That I'm going out of order on the agenda because Chris Cook's going to join us when he can. He got pulled into an orthopedic urgent case. Not unexpected in his business. For anybody who is joining on, although maybe give it till once it hits 7 o'clock, which will be in a minute. If you want to put your name and you practice in the chat, I think you all know each other, but just in case we will have some guests joining us. So feel free to do so.
Hey, LJ.
Hi, Renee. That was just so cheerful. That's extraordinarily cheerful at the end of a very long day. Thank you.
Yeah, right. I know. We may have someone new joining us. I don't know if she's going to make it or not, LJ. Laura Markwick from NP Family Care.
Oh, great.
She wanted to join the group.
Wonderful.
And I sent her the invite, but I don't know if she's going to make it or not tonight.
Okay.
Did you mention everyone to throw their name and practice in the chat?
I did, and I was going to remind again in a minute. The problem is that, hey, hi, everybody. So anybody who wants to start, well, it looks like you already have. Look at you guys. What a good team. Thanks, Carolyn, for leading us off. Perfect. Brophy, you just go with your last name, Pat? That's all you need to be known as, Brof. Perfect. Everybody, we're going to give folks a couple more minutes, and then we will get started.
Yeah, that's a long-standing Brophy tradition.
Is it just last name in the chat, or just referred by last name?
No, just referred to by last name. So Brophy. My kids get the same thing.
It's a good name to shorten to one syllable. That's cool.
Well, it's kind of like Murph idea.
Murph.
Yeah.
Good point. Oh, we're almost filling up a whole screen. That's usually my indication. We fill up a full screen and then we go on to the next one and we start, or we hit 7:03. Whichever comes first, you can count that on your clock or on your screen. Gail Mosher, your first grandchild. That's fantastic. I'm reading in the chat if people don't think I'm just making things up or having a conversation with myself. Yes, congratulations, Gail. That's terrific. And how old is your first grandchild? Are you willing to unmute and tell us? Is this a grandbaby or is this a baby a child you've been waiting to see because of the pandemic?
Hi, no, he's 3 weeks old, and no, I'm biased because I think he's brilliant, but isn't it crazy? My daughter thinks I'm this way with all babies, but isn't it funny when it's your own and your grandchild, you're just over the moon. So I'm over the moon at this point. Yeah. It's amazing. But you know, Brooklyn's a ways away. That's the problem. Yeah, it's a ways away, but All right, they're doing great. And, my daughter's a landscape architect in New York, moving as fast as you can, but boy, she's doing great. So she doesn't need a lot from me. I'm not offering advice unless asked. So that's and her husband speaks Polish as their pediatrician does. So that's wonderful. They've got this interaction between Polish and English. Like, it's really wonderful. Yeah. Yeah.
Oh my gosh, congratulations. That is that's a great story and a great way
Yeah.
to start our meeting.
Joyful time.
Good. All right, we're gonna have a joyful meeting. How's that, everybody? That's the word of the evening. I won't make you all give an individual word. I won't call you out that way like I do sometimes in these meetings. Everybody's been putting their name and their practice or what they do with an AHP in the chat. Thank you for doing that. I think you all received the agenda prior to the meeting. But I'm gonna just let you know we're starting with a welcome, and then we're gonna do a few announcements, and then we're going out of order right from the beginning of the agenda just to keep everybody flexible because or Dr. Cook, Chris Cook from Peds Orthopedics is planning to join us, but he just got pulled into a supracondylar fracture case, and so he will join us as soon as he can. So we're just going to be flexible and moving things around in the meeting. So we've got a few announcements to lead off with. Renee, do you want to start with some of those? Or are you okay with me doing those?
Go ahead, LJ. You can do it.
All right, awesome. Thank you for sending me the notes. So first thing is we just want to let people know well child check roadmaps, the roadmaps that we designed a while back when we were working to expand our back in stock. Many of you have been reaching out asking for more, so please just reach to Renee Sutton and Renee will get you whatever copies you need. So those are in and thank you. We appreciate that you guys are using them and that they've become a good resource for the teams. Second reminder for those of you who were on the AHP noon call today, we talked about the fact that there is a grand rounds, AHP grand rounds on June 17th. All pediatricians and family physicians are invited to attend. As I mentioned on the call today, it is an adult-centric grand rounds. So check out the agenda, still very great information, but we decided to go ahead and do a pediatric-centric or a child-centric grand rounds in the fall. Because as we were looking at things, we felt like there was a lot that was happening right now in the adult space that we wanted to be able to report on. And there's a lot of things that are being built right now and we are working on in the ped space, and it would be a better time to be able to talk about them. Things like the universal newborn telehome visitation pilot, the work that some of the practices are doing around developmental screening, and then sort of to loop back around, obviously, on some of the other initiatives and some things that are in the wings, but will be definitely out of the wings and on front of the stage by the fall. So stay tuned for the dates for that, but you are invited to attend the grand rounds on June 17th. It will be a Zoom meeting. Of course, we're not back to in-person and cocktails and time to socialize yet, but hopefully, who knows, by the fall. Probably not still, but if we were, that would be awesome. The other thing we wanted to let you guys know, just as a follow-up, and rather than putting it on it as an agenda item, just wanted to make you aware, our last meeting when we were together, we did a little preview of the provider engagement report to get some feedback on whether that seemed like a valuable tool. You guys were really helpful, gave some great feedback. We wanted to let you know that we are working up the PEDS version of that, and we're going to have new mock-ups that have specifically PEDS measures for you guys to review at the next meeting. So that will be a topic coming forward. And just wanted to make sure you guys knew that your feedback around that was really helpful. And then the last thing I just wanted to mention to folks, one of the areas of clinical focus that we've had over the last year and a half, almost 2 years now, is the long-acting reversible contraception or LARC initiative. Many of you have participated in this, and many of you actually are trained providers, or you have providers in your practice who are trained to place LARC. But in the spirit of focusing I guess you're never finished in this, but really focusing and making sure that we all are as skilled as possible in the reproductive health counseling for adolescents and young adults. And then also, if there are providers who would still like to train in the LARC initiative, the Hockelman Center is ready and is now doing the reproductive health counseling training by Zoom. So for practices that, you know, may have done this several years ago, but maybe have new providers in their practice, for practices that might like to engage some of their other staff, their nurses, you know, in this work, they are ready and available to do that training for your group. And then also there is scheduling that's happening now for in-person LARC placement training, if anybody's interested. So I will say right now, Sarah DeVicki, I know you're on here, so I am working to connect Fairport. If you're not already connected to the Hockelman Center, they are definitely know that you guys are interested and, you know, for the counseling training, and then we can work further with that. So if there's anybody else who's interested in doing that work or having one of those trainings provided for the counseling or for specific LARC placement training, please just throw your name in the chat to me. You can do it privately or publicly, or send me an email. Okay. And that's everything for announcements. So I'm
Actually,
gonna,
LJ, can I pop 2 more on the list? I'm sorry.
you can always do that.
We have some new faces. One I want to introduce is Laura Markwick. I did see her pop into the call.
Okay.
So welcome, Laura. She owns and operates NP Family Care of Rochester. So she's a new primary care office joining AHP. So we're so happy to have her. And I want to turn it over to Daryl because I am remiss in adding to your special agenda, LJ, that this is Elisa Stetzer's first meeting. So I'm going to ask Daryl to introduce Elisa to our group.
Thank you, Renee.
Can everybody mute? There you go. That was almost like, I think that was awesome because that was almost like Elisa, you should have like walked in. Like,
Yeah,
yes,
really.
to the-
That was
Okay.
great. It is my great pleasure to introduce you all to Elisa Stetzer. Many of you may have met her along the way. She has been in the role of Senior Director for Care Management for AHP, the Primary Care Network, as well as the medical center since mid-March. And Elisa, prior to this position, was the Director for Care Management for the Primary Care Administration, Primary Care Network. So she has lots of experience overseeing care management, lots of leadership experience there. Prior to her care management role, she was working in medical surgical nursing at Strong for several years and comes to us with a very long experiential you can tell it's 7 o'clock at night, I'm losing my words. She is extremely experienced in working with engaging physician groups and in helping with teaming and focusing on population health, even before population health was so much of a focus as it is now. So she's worked for the advisory board in Washington, DC. She's had a consulting business nationwide prior to joining us, where she's done work of this sort with systems, health systems across the country. So she comes with a wealth of great experience to the role. And I just feel so happy to know that care management is being guided by her skillful leadership. And so welcome, Elisa, and welcome.
Thanks, Daryl. It's so wonderful to be here. I really appreciate that warm welcome. And it's lovely to be spending time with you all in this advisory committee for the first time. So I'll be noticing and listening and watching and looking forward to getting to know this group and all of you over time. So thanks.
Thank you for that. Elisa, I feel like you've been with us for a while. I wasn't even thinking about this being your first meeting. That is kind of incredible. Elisa is already really just a fully integrated part of the team, and we really are so appreciative that you're here with us. Thanks. So I think we're going to move through the agenda. Renee, I'm just going to ask you to be, you'll need to let Chris Cook in when he comes to the table or to the Zoom meeting. So if you can let me know that. But for right now, I think we're going to actually turn it over to you, Renee, to talk about upcoming PCP payments and incentives.
Okay, great. I just wanted to make everyone aware of just some recent payments, what those, the background on those are, and what you can expect in the coming weeks in terms of payments to primary care from AHP. So about 2 weeks ago, everyone received a FLIPS incentive. Hard to believe. I think this is like our 3rd year now where our FLIPS jog, this is our partnership with FLIPS to work on their measures. They're accountable for improving outcomes for the Medicaid population. Our partnership with them really continues to reap benefits, and they continue to earn incentives and dollars from the state for their work, which is really your work. And so those incentives that they've earned, they've paid to AHP's share, and we've passed that on to our providers. So you all received an incentive, I think it was in the amount of $1,000 or $1,100 per primary care physician. So those went out about 2 weeks ago. Just earlier, just last week, we did pay practices who we knew were vaccinating patients within their practice, those who have stood up COVID-19 vaccination efforts within their practice. We paid just a small cash stipend with the intention to recognize you for your such an important contribution to the community's health. It's just such a critical strategy for overcoming vaccine hesitance to be able to, in the moment, offer vaccine to patients. And we're grateful for all the effort that it took, because although we know our partnerships with the Department of Health and the Finger Lakes Vaccine Hub are good, and they provide a lot of resources, there's still money, time, materials, and effort on your part to do this. And we just wanted to provide that small cash incentive to recognize you for that and acknowledge that. So that went out last week. So practices with 1 or 2 physicians earned a stipend of $1,750, and those with 3 or more physicians earned $3,500. And then coming next week will be your first quarter 2021 clinical integration payments. So this is that quarterly payment that AHP makes to our private practices at the amount of $1 per member per month in the quarter. So $1 per member for 3 months per month. That for each of your attributed Excelis and MVP members, all lines of business. So those went out or are going out next week. So any questions or issues with that, let me know. And that's what's coming up in the next couple of weeks. So let me know if you have any questions.
Any questions for Renee? I'm going to figure out some way to get you guys talking before we go too much further, but I won't make you do it yet. Thanks, Renee. That's great. So next I'm going to have Willie and I are going to talk to you a little bit about the 2022 Arcadia Measures. And Willie, I wonder if you want to share your screen.
Actually, I sent it to Renee, so hopefully.
Oh, Renee.
She's going to be our
patience, grasshoppers, it's coming.
Patience, grasshoppers. Wow, I love that.
I got to run the meeting, let people in, share my screen.
I know you get a little bit of multitasking here. I hope you've had some caffeine tonight. Okay, great. So that's the title. Willie and I are going to walk you through this a little bit. And if we can have the next slide, Renee, that's great. Go ahead, Willie.
So I'm off mute, right? Yes. So we'll be talking about taking a look at the 2021 measures. LJ will look at the performance through March and provide an overview of this year's measures. I will then review a single definition change, what we currently see in Arcadia and what to expect moving forward. And lastly, we'll talk about working together on data issues. Next slide.
Thank you. Now, before you turn, she did it already. All right, I was going to try to prepare the team. I said it was going to be a joyous meeting, and now this little dashboard thing came up, which is making everybody go like, ugh. So this is, if you remember, we have an enterprise population dashboard, which looks at trailing year. So think about this. What this trailing year represents is March 2020 up through, or yeah, I got this right, March trailing year 2021, because that's where we have our data up through. So this is a view of the pandemic and how it impacted pediatric preventive performance. So we show this only to say that we can't look at right now just the data going forward from this year. So we know that in terms of overall performance to contracts for the 2020 year, PEDS did a good job overall in well-child measures, in childhood immunizations, and lead screening. It was more difficult for us in terms of some of the adolescent measures. And I think that that's a reflection in many ways of the pandemic and the prioritization we made collectively around essential visits. But this is really like a snapshot of seeing the whole thing without any buffering on either end of the year. This is going to get better as the year goes forward. I mean, that's just the bottom line, because I think you all can reflect on the fact that the trend of seeing patients for well-child visits, which is, immunizations and lead screening, which is the crux of pediatric preventive, has been much better in 2021 than it was in 2020. So we say that just to show you where it is, because we want to be transparent. But I would tell you by the time we meet next, that dial should be moving up. I don't know if we're going to get to the full green. We haven't been at the full green. We've got some work to do. And that's one of the things that I'd like to just put a pin in for a moment. And then when we have open discussion later, I do have some questions for you all about approaches to try to help us in that space. Okay, next slide. Thanks, Renee. So this is just a reminder slide. And I know many of you are fully familiar with this, but we like to just talk about the annual measures and explain again that the Arcadia measures really relate to three areas: contract, threshold, and definition. So in terms of contracted measures, these are the measures that we have agreed with the insurers to be accountable for. And in the PEDS space, they really are preventive measures. That's what we have, and Willie's going to go over that in more detail. And there's a certain amount of points that are assigned to each measure, and that's how we basically determine gain share and how we look to see how we perform to the contract. Threshold is a really important concept that I like to go back over, because I think sometimes when people look at percentages that are listed, they think we're talking about percentage as opposed to percentile. So you guys know this, there are percentile targets that range from the 25th up through the 90th. And these are based on national and regional benchmarks. So there's a big difference between the percent of performance that would get you to the 90th percentile if you're looking at childhood immunizations versus the percent that would get you to the 90th percentile for example, adolescent combo 2, which includes HPV vaccine. And I mean, that's the best and clearest example I can give, because in general, the performance to the adolescent combo 2 nationally is pretty poor. And so the national and regional benchmark is lower. So it's important to look at that and just make sure that you know that we're talking about percentiles, not actual percentages. And then the last thing is definition. So we don't have control over some of this stuff. We don't at AHP, and you don't in your practice, which is a little bit frustrating, but it is what it is. The national and regional benchmarks are set based on performance across the region, and the NCQA HEDIS national standards are something that get set. There is a comment period for them, and I have to say that many of you and many of us have offered comments along a number of these measures. I would call out, for example, Menactra vaccination and the requirements for timing for that, even HPV. Sometimes the HEDIS national standards do not correlate with necessarily other guidelines that we may be following, whether it's AAP or ACIP, and that gets confusing and frustrating. One thing we're trying to do with Christy's help going forward is we want to we're pretty good at advocacy in PEDS, right? So we'd like to be able to formalize a little more advocacy around this. So when the next comment period comes up, we're going to craft a message, share with you, and make sure you have the access to the comment period So you guys can comment in with a, even a louder collective voice to see if we can get some movement in places where things just don't line up. Any questions on that from anybody? Okay, next slide. Okay, great. So when we look at the pediatric initiatives, I just wanted to go over with you what the measures are in PEDS, and then the points that are assigned to them and why they have changed a little bit. So these will look very familiar: adolescent immunization combo 2, childhood immunization combo 3, lead screening in children, and well child visits, which are in the youngest age group. You'll see there's a big X next to well child 3 to 6. So I think most of you are aware, but if you're not, that has been removed from the listing of measures and has been replaced by a measure which is well child, which is 3 up through 21. So well child 3 to 6 has been removed. Well child 3 to 21, nobody has any baseline measure on this. Nobody has baseline performance because nobody's been looking and tracking it in that way. So we are going to be tracking and looking at that. We will share data with you about, sort of our network's performance, about your practice's performance, but we don't anticipate that this is going to actually land on our pediatric initiative measures for a couple of years, likely, while they're collecting data on this nationally. So just wanted you to be aware of that. Depression screening and follow-up is listed on here. You saw me skip over it because even though that is a measure that we're actively working on, that is not something that we are reporting on. That's not something that you're accountable for in the traditional way that a pediatric measure would be accountable for. So there's no points assigned to it. That's why it's got that black beside it. We do all feel that it's a very important initiative. I don't know, I'm sure you guys have realizing this from your own experience of what you're seeing in your practice, but we're hearing from Excellus that depression is becoming the second leading diagnosis among children age 6 to 12, which is just like overwhelming to even think about that. But I know from the stories you've been sharing that you're feeling overwhelmed by the degree of mental health and behavioral dysfunction and rising diagnoses in the population. So it makes the depression screening and the follow-up and connection to services ever more important. So I just wanted to say your feedback in that space has been so important and so critical. Willie and Christy and Elizabeth's on maternity leave right now, but the team has been working very hard with individual practices to assure that we are making the right connections so that your data is being captured, and just wanted to reassure you that that is a high priority for us to assure that the data is accurate before you would ever be asked to be accountable in a measure. So, and so because we needed to redistribute points, you can see that adolescent immunization combo 2 is going to be worth more points as our childhood immunizations, lead screening and well child all went up a little bit in terms of their point distribution. We dispersed those equally across those measures to not make anyone more of a heavy burden. But they all are part and parcel of what we do in primary care peds and family medicine. So I hope that that won't come as a surprise to folks. Any questions on that? It's a quiet crowd. Okay, Willie, I think you're next. Or am I still next?
Hey, Laura Jean.
Yeah, thanks.
Can I ask a question? This audio.
Carol, you just muted, but you had a lot of feedback before.
There's a lot of background. Can you hear me?
Yes, you sound like you're.
I think it's an ancient computer. Maybe I can type my.
I think, Carol, you've got 2 windows open. Doug Bennett just diagnosed the issue. Thank you, Doug. If you close one of your windows, you might be able to speak. Do you want to try it again, Carol? Or are you?
Can you hear this now?
That's a lot of.
I have no idea what's going on.
Carol, you've got your you've got your phone and your computer both picking up your sound. That's the problem. So
mute the phone.
I'm going to sign in and come back.
okay.
Okay. We will get to Carol's question in the slide.
My dog's looking at me like, what's going on? You're killing me.
It was almost like she was like floating from outer space. That was like, just, I don't know, it reminded me of some show from my childhood. I can't remember which one. Lost in Space, maybe? Okay. So Willie, I'll let you speak, but then when Carol's back on, if we can. No, you're muted.
Okay. So looking at the 90th percentile percentages that LJ was talking about, big change was the immunization combo 2 that went up almost 4%. Still a relatively small 39.9 though. Immunization combo up maybe almost 1%. Lead screening actually went down, and through the last couple of months, LJ made me double check and triple check that point because we're so used to it increasing. And the well child up to actually 90% for the 90th percentile. So, next slide. And the one definition change for this year was for well child, the 15-month. The telehealth visits now count towards satisfying the measure. All the other definitions remain unchanged.
Yeah, and I think we've had lots of conversation as a team about this in pediatrics and with our family medicine colleagues too, that, obviously well child visits are not the visits we want to use telehealth for in general, but considering what happened during the pandemic and what people needed to be able to do assessments for kids, I think it is important that those telehealth visits do count towards the measure. Obviously, we recognize that from a reimbursement standpoint, there needed to be a closed loop with some in-person time that was, required by the insurers. But we don't know. I don't know how long that restriction will remain removed. But once they change a measure, it usually takes a year or 2 or maybe 3 before anything else changes in it. So we'll keep you posted on that one.
Carol's back on the call. LJ.
Awesome, Carol.
Okay, can you hear me now?
So much better. You are clear
Great.
as can be.
I don't know what is going on. I have this old ancient computer and half the time I can't figure out what's going on because of the speakers. Anyway, I had reached out to Willie about this regarding this well child 50, the 15-month measure to have 6 visits, by the time they turn 15 months. Probably a lot of practices have this, but we have these transfers that come in well under 15 months of age. They might come in at 4 months or at 6 months or even at 12 months. And they may even be from practices that are just local, like that, I'll go to your practices, maybe go to Genesis and Genesis gets some of ours or whatever. And I know for sure that they've had these well child checks. They send over the records, but when they become our patients, it doesn't look like we're getting credit for that, but we're also getting them on our list of not meeting, as being gaps in care. So, Willie suggested just get a list of some of those patients and then just individually, send some kind of an encrypted note to me, and maybe we can address that with HP. I don't know how often it's happening, but it's happened quite a bit. For just the 5 physicians that we have in our practice. And then they're ending up on the gaps in care. I mean, I just looked yesterday and there were some that were there, and some are getting 5 of them, but they join us at, 4 months. So they've missed the 2 week, the 1 month, at least the 2 month, and sometimes the 4 month. But again, they may also be from other areas that AHP doesn't capture. So do you have any suggestion on how to make it easier for all of us?
So I really appreciate that you brought that up. And this is something that we really are looking at very carefully internally to figure out a better solution and, just kind of let us know if those patients are there. I think, right now, Willie, correct me if I'm wrong, but Arcadia is not set up for us to be able to enter in past well child visits like the way you would when you accept a transfer patient and you update their immunization record, right? or you can update if they've had a lead screen. So we're really trying to work on that internally. And I just want you to know you are not the only person to bring that up. And I think somebody else, Jen Lessick, may have just mentioned in the chat. Our goal is not to penalize you for accepting transfer patients. Our goal is not to penalize you if you're accepting newborns out of the NICU who will have missed their first one or maybe two well child visits. So we're going to figure out how to fix this year. Willie, do you have other things to add in terms of process?
Carol, you're a med in practice, correct?
Yes.
Okay. So in the last month and a half, I've been talking with MedIn, and they're actively looking for ways that you can put in previous appointments with other providers like you do for the immunizations and so
Or
forth.
for the lead screens, yeah,
Yeah.
sometimes. The leads are being, obviously we can input those and, we find those in the transferred records mostly. And then those meet the, the quality measure as well too. But that would be great. I mean, obviously it's going to be, on our honor system, but I mean, why? Of course.
Yeah.
It's important for your documentation and your record too. So we would trust that honor system, right? We're not going to come and look at your transfer records. Willie doesn't have time for that. No,
We don't even have time for that.
No, I know, but I do think like that's a solution that then is not you keeping a list of these patients and then reporting. But so that's a really, really good point, Carol. And it's something that I'm not sure if we're seeing that many more new transfers, but it certainly is an issue that's coming up more. And I don't know if some of it has been, sort of more transitions, particularly within the pandemic, people, dropping off of one insurance onto another. It's hard to know why we're seeing more of that right now, but we are. So thank you for that.
Okay, thanks. Thank you, Willie.
Yeah, hopefully MedIn will come through for us. Okay, what slide are we on? Next slide. Currently in Arcadia, you're seeing the measures AHP chose for 2021. So the 4 measures along with the depression screen with the thresholds and points. But however, until the next Arcadia upgrade, the 2020 measured definitions will be used. It's not that big of a deal for pediatric practices because we only have that one small change that shouldn't affect the performance too much. But the upgrade is tentatively scheduled for mid to late July, at which time the 2021 definitions will take effect. We all know that waiting until July for new measure definitions isn't ideal. So there's hope for next year. With this upgrade comes a new Arcadia measure engine. So the measure engine removes the need to perform an upgrade to get updated definitions. So if it is as promised from Arcadia, we are expecting that next year's definition should be available shortly after the claims rollout, run out, I should say. So hopefully we can push the timeline for having new measures up 3 to 4 months. So crossing our fingers on that one. Next. So how can we work together on data validation? Just because it's near and dear to my heart. So have someone at your practice look at the dashboards on a regular cadence, daily, monthly, quarterly, whatever works for your practice. As soon as they see performance in Arcadia doesn't match what you expect, let me know. When they see that a patient isn't closing a gap and should be, let me know as soon as possible. We don't expect a practice to spend hours researching why patients don't close a gap. Let me do that for you. We want you and your practice concentrating on the great clinical work you're doing. So let me take care of the investigation by working with Arcadia, your EMR vendor, and the practice. So don't spend your time on that stuff. Lastly, some reasons why performance may look off could be through data delays. Freshness of the data depends on how frequently the data is provided to Arcadia from the EMR. It could take up to 4 days to process for Arcadia after the data is received. So it could be a little bit of a delay there. And then prior month claims are loaded between the 20th and 25th of each month. Lastly, A reminder not to send patient PHI data over unsecured email. If the practice has no way to send a secure email, just send me a note asking me to send a secure email, and then you can respond back with your PHI data. So, any
Thanks.
questions?
So I just wanted to underscore one thing that Willie said, and I think that this is a shift within HP a little bit, thanks to the great team that Willie and Christy and our optimization team as they work with practices. We really do want to be ever more involved and helpful in this data piece. And so what Willie said about we want you guys to be doing the clinical work and let our team support you when things don't look right, but we for the moment are relying on you to help us recognize early if something's not looking right for patients or you're seeing gaps. So if you can really, message him, follow up with that, it also really helps us because, if there's an issue that is repeated over and over again, like the well child visit issue that Carol brought up, then we know it's a bigger problem, it's a system problem, and I think we're better at coming up with a solution for that affects everybody. So thank you for that. And Willie, thanks so much. You've been working really hard with all of our practices and we really appreciate you.
Sure.
You bet. So in my flip-flopping of the agenda, we're going to close off on that part. And actually, Dr. Cook has joined us. Is that right, Renee? There you are. Hi, Chris. Thank you so much. Oh my gosh. Thank you for being willing to join us after taking care of a pediatric patient.
Yeah.
I will let you introduce yourself, but I just wanted to say, one of the things that's been nice about these meetings and bringing you all together, representing all of the pediatric and family medicine practices within the HP network, is the chance to tie back to Argyle Center Children's Hospital and the providers and specialists and leaders there. For those of you who didn't see, Pat Brophy is on our call and tends to join in these meetings, and Dr. Cook from Pediatric Orthopedics has been willing to come and join us to talk a little bit about Peds Ortho and some new things that are happening there to keep you guys up to speed. So there you go, Chris.
Sure. I got a couple of slides. Is that okay?
Absolutely, please. Feel free to share your screen.
There's only a couple, not very many. Have we got it there now?
Yep, it's up there.
All righty. So just, we've thought a little bit about what's happening with our program, and we've got a couple of initiatives which I thought maybe some of you know about and maybe some of you don't. And one in particular was about trying to improve our communication with our pediatricians and family practitioners. And we thought that we would try and explain that to you and maybe take an opportunity to tell everybody where we are at the moment. We have 3 pediatric orthopedic surgeons, and we have Dr. Rubry, the chief of orthopedics, who does quite a bit of pediatric spine. We have Dr. Hammert, who does the lion's share of congenital work in Western New York, and he's actually the president of the American Hand Society. We have Catherine Rizzoni, who's a non-operative pediatric sports medicine person trained, who are all part of what we do at the moment. We also have some other individuals. We have Kim Ingram, who's one of our physician assistants, and she's been doing pediatric orthopedics for over 20 years, and the past president of the Pediatric Orthopedic Providers Society, or POPS. Kaylee Spusta, Emily Herman, a previous NICU nurse who's now our nurse practitioner. We've just hired Justine Ross, who's just out of school, and Karen Drury, who is been a physician assistant with a general orthopedist for 12 years and is coming here to join us to do pediatrics. The department has also hired Sarah Landers, who's coming back to do pediatric sports medicine and women's health. and she will join our burgeoning pediatric sports medicine group. And then we've also looking at hiring a 50-50 clinician research position. We do outreach to all the Greece and Webster and Penfield. We're not in all these places every day, but we have clinics regularly every week in all these places. With COVID, we haven't been doing Auburn and Horseheads, but they'll be starting up shortly. We also have pediatric orthopedic urgent care every day. We also have a specific orthotics and prosthetics. This is our pediatric space now at Clinton Crossings, which has its own radiology section. And in particular, it has the EOS machine, which can take a Scoli film or a long leg film with about 100 times less radiation than a regular film. We do a lot of different stuff. We see a lot of people every year. And we now are developing a sports medicine program. We've got Sarah Landers, and Dr. Maloney is also going to, even though he's chief of the sports division, we're doing this in conjunction with the sports division, and he'll become part of pediatrics as well. Alrighty. We all do a bunch of different things and have different interests. And we are in the process of recruiting a pediatric orthopedic scientist in collaboration with the Musculoskeletal Research. And we've now actually had applications and are interviewing candidates for that position. I think in the future, as you all know, there's this new orthopedic building, and this is a rendition of what it would look like. And pediatrics will have its own pediatric clinic space, pediatric pod that'll have 14 exam rooms, a new x-ray facility just for pediatrics with that special EOS machine. And now instead of having a cast room where there's a bunch of people in the same room, every cast room is individually stocked for an individual patient. And there will be also day surgery available in that same building. So we're very much looking forward to that. Well, one of our initiatives, though, that we were discussing is that in order to improve the communication between us as physicians and our physician colleagues, you people, is we've now got a phone. I have an iPhone. It's right here, and it's manned from 9 to 6 every day. It's not for clinics to call up and look for appointments. It's for you guys to call us if there's a problem. So if there's a problem or a complaint or a problem getting an appointment repetitively or a clinical problem and anything like that, it's a way for physician to physician communication that we're making available so that we can create better relationships with our colleagues, not just in the hospital, but in the area. So that was our thought. Any thoughts or questions?
I wanted to give the pediatricians and family physicians and nurse practitioners on the call an opportunity to, share with Dr. Cook. There is an email that will be going out this week. There will also be information being posted to the Golisano Children's website on the provider page about this peer-to-peer phone call service for healthcare providers, primary care providers, to connect with orthopedics. But we wanted for Dr. Cook to have an opportunity to talk with all of you first and get your feedback about that, and ask any other questions you might have about orthopedics. So this is your time to speak up, team. And Chris, I don't know if you know all of the pediatricians or family physicians on the call. So if anyone's got a question or a comment that they'd like to share, please just identify the practice you're from too. That would be great.
And I don't know if there's any hockey fans on the call, but let's go Montreal.
You got a reaction out of Willie for that.
Yes,
he
I
happens
did.
He happens to be on my screen, and I saw that.
Sorry about that. At least during the playoffs, not like the Sabres.
Oh gosh, I see a couple people unmuted, so I'll let you guys talk. I think Kathy Goodfellow.
I'll take a chance. I'll start out if you like. I just wanted to take a chance to tell Dr. Cook how much I appreciate ortho looking out for our patients, because that's not what we find everywhere. And we are so appreciative that we can call and get somebody seen. We try very hard to be careful who we refer and to not plug things up. But when we call, it is so nice to be able to fit them in and get somebody an appointment. And they are so relieved when they can go just from our office to theirs if need be. And I just so appreciate that. Thank you.
Thank you.
Any other comments about the peer-to-peer line? Does that feel like something that will be helpful to you all? You see some head nods.
Hi, LJ. I can take a turn.
Awesome, Katie. Thank you.
This is Katie Edwards. I'm a pediatric nurse practitioner from Stony Brook Peds. And I can say, we've got the office in Dansville and Geneseo. So coming from more, rural areas, that we truly appreciate the urgent care after hours clinics. As many of you guys, those evening hours that can go into 6, 7 o'clock at night, a kid has a fall at school or a fracture, and sometimes you worry about having the kid splinted overnight for just pain control. And you guys have always been really amazing at getting kids in really quick, if not that night, the next morning. And I know that is really appreciative to us and our families. And I think the call idea is great. Hopefully it won't get bogged down with things that aren't helpful, but I know if you get us the number, we'll use it.
Well, that's right. We hope that it's a communication tool for practitioner to practitioner, not secretary to practitioner, obviously.
Ikuya Asante here. I work in Canandaigua and Farmington Peds, and I just want to say we appreciate having the satellite location in Victor, because a lot of the families are able to go there for their follow-ups. And then I will definitely use this peer-to-peer phone number. So, so I appreciate that too. Mm-hmm.
Well, good. I like Victor Clinic too. I do Victor Clinic on Friday afternoon because I live 5 minutes away from there. So it works out well for all of us.
Definitely.
That's great. I think Jen Lessick I don't want to call on you if you hadn't unmuted, but I thought you unmuted at the same time before Jen.
Yes, I was going to say something, so thanks. I appreciate after hours tremendously too, as working a lot of Wednesday nights and being able to get kids in acutely. It's really, really helpful. The only other question I have as far as communication is a lot of the times I will send referral information of kids that I want seen for scoliosis, et cetera. And it feels like sometimes those faxes and or communication doesn't get to the clinician that ultimately ends up seeing the child. So I don't know, when you provide the peer-to-peer line, if there's another better fax number we could be using that maybe we're not, so that the clinicians can get our notes.
Yeah, I don't know if that's been a chronic problem over time. I do know that we've definitely had difficulties along those sorts of lines with COVID because our people have not been in the office on a regular basis. Right, they've all been at home, and we only have, like, my secretary is only in the office 1/2 day a week, and that's all they're allowed to do. Hopefully we'll have more ability to improve upon that once all this mess gets behind us. But I hear you. I've even made a note.
Perfect. Thank you. I appreciate it.
I think Jen's point, maybe, Jen, wouldn't you agree? It's probably all specialists. It's not just orthopedics. I think it's more of an epic system-wide problem. But having said that, we also appreciate orthopedics. Thank you.
And I do second that it's across the board. It's not just ortho that happens with. Absolutely.
Right.
Yeah, and I think based on feedback you all have provided before and conversations we've had before, just around communication, sort of to Epic within Epic, that has been a chronic problem. It could be even worse, Chris, because of the pandemic and people being off-site, but I think this predated COVID. I know it's something that Pat Brophy has been sort of elevating throughout GCH and the specialty teams. And also obviously within the digital health and Epic platform. So I hope we will see something different. Pat is fully aware of this. A number of you reached out with more lengthy emails around this, around the direct communication and opportunities to improve that. So we'll continue to follow up on that. Great. Any other comments for Dr. Cook or questions? Well, I know when I heard about the peer-to-peer line, when Dr. Cook and the orthopedic team gave me a preview of that about 2 weeks ago, 3 weeks ago, maybe now, I was like, oh yeah, that is just a really good idea. And I would say to you that I think that that's a very successful thing. You know, that may be something we'd appreciate feedback. I would say from the GCH end of things. I'm wearing my GCH hat now. You know, if there's other specialties where that might be particularly helpful to think about. So, you know, let us know how that goes. Dr. Cook, thank you for joining us. We really appreciate you coming in.
I have to head on, but thank you for the opportunity, everybody. Have a good evening.
You too. Thank you for joining us.
Night.
All right. Thanks, you guys. I hope that those sort of little bits of information and, you know, connection with the hospital teams are helpful. I know that as we've gotten more separate from the hospital and from the specialty teams, it's hard to know everybody who's on the teams anymore. Even if you trained here and you've practiced here for a long time, there's lots of new faces. So I know that Dr. Brophy is hopeful that we can continue to keep these lines of communication open and be able to establish a little more personal connections. So the rest of our time together for the next half hour really is open table discussion, which means you're going to have to unmute and talk. But that was a nice little warm up with Dr. Cook. And what we really wanted to do, it's not the same as sitting around the table in the conference room where I think, you know, conversation flows more readily and we share, you know, ideas, barriers people are experiencing, concerns that they have. But we wanted to put two topics on the table for open discussion. One is just around COVID vaccine. And then the other is I would really love to hear you guys talk about back to school for the fall, what you're worried about, what you feel is needed. I am going to take some serious notes while you all talk, because that will be an opportunity for me to bring that information back to the School Reopening Safely Task Force, you know, back to PEDS ID and epidemiology and the county health department as we're looking at protocols and screening and testing and all of that stuff. So I think this is just a chance, and you guys can put anything else on the table that you want. So I think if it's okay, we'll just start with vaccine for a moment. If you weren't on the call at noon, you didn't hear me and Shad give you guys all a huge shout out. But for those of you who led the way without any help in standing up COVID vaccination in your practice, holy cow, you guys are awesome. And for those of you who came on board really quickly with that first meeting we had, and Kathy, it was kind of funny. It seemed like a game show. Kathy Hiltunen was like, I can take care of 2 practices. And you guys were like, pick me. And you were all messaging in the chat. Like the number of practices that got started very quickly with that, with some extra help from, you know, whether it was staffing from the United Way Volunteer Hub, whether it was the county health department kind of stepping in to help, whether it was Renee's unbelievably organized and thoughtful emails that made it so easy to click through and figure out what you needed. You guys are doing a great job. And I just wonder if people want to talk about concerns they have or barriers or solutions that you guys have come up with. This is your chance to kind of share some of that because you're all really good in this space. So vaccine is first.
LJ, it's Mary Beth Robinson.
Hi, Mary Beth.
I have a question rather than a comment.
Okay.
Vaccinating is going beautifully because the health department has made this the easiest possible thing to do. But today at lunch, we talked about if kids get chest pain, and a lot of kids, you know, were worried they might just have anxiety, but you don't want to look the other way. When 3 or 4 days after their vaccine, they call you up and say they have some chest pain. Do you have any suggestions on how urgently we need to get the troponins and the EKG? And if that needs to be really urgent, is there a way to do that through cardiology? I mean, especially the EKG. How do I get an after hours EKG on a Sunday?
So great topic and question. We talked about this a little bit at noon. I'm sure all of you are well aware of the reports from the CDC and sort of the cautionary comments that have come out from the AAP as well. You know, we specifically reached out to George Porter and the pediatric cardiology team to say, like, are you guys seeing an increased number of cases here locally? You know, what's your sense about this? And George stated, you know, they're not seeing any increase at this point. And in fact, for all of the screening that you all have been doing, which is still, you know, necessary and important, they really have seen very, very few cases of any significant myocarditis or cardiac dysfunction as a result of COVID infection, much less the vaccination. He did say that post-vaccine, if a child develops shortness of breath, chest pain, palpitations, or fatigue that is significantly disproportionate, you know, to and not explained by other symptoms, then it is appropriate to assess and then do a workup. And they continue to have a system in place, utilizing the nurse practitioners and their physicians to be able to take cases readily if you're worried about a kid. I think in terms of urgency of evaluation, you know, based on my conversation with George, it would depend on how that individual was presenting. You know, if they're presenting with clinical signs and symptoms that are really concerning to you, or as concerning physical exam, that's obviously a more urgent workup. Otherwise, you know, working up within a 24-hour period, or if you're not convinced, you know, what it is, being able to follow up on that patient is reasonable. So I think that, you know, the number of cases that are being reported right now still are not higher than what you would generally see in the general population. But it's just, as Chad Teeters was mentioning today, there is no vaccine that's ever been watched so closely across the whole country and everywhere, you know, so that with the many, many, many vaccines that have been given, this is really a small number, but still something that we should be attentive to. I hope that that helps. I think if you have a question about it, I'd call Peds Cardiology and ask for, you know, ask for their help in terms of further workup if you're concerned about a patient. Do any of the other providers have thoughts about that? Has anybody been seeing any cases they've been worried about with this so far? Okay. Mary Beth, did that help? Oh, Sarah, go ahead, Sarah. Yeah.
Oh, yeah. Just to throw it out to the group, I'm wondering if anyone else has seen anything like this. I saw a 13-year-old who came in, and for unrelated reasons, I did orthostatics and noticed that his heart rate went from 90 all the way up to like 160 with no change in his blood pressure. And the only new thing was the COVID vaccine. So he's seen, actually, I think he saw cardiology today. I'll see the note. But has anyone experienced anything like that?
I haven't experienced it, but I know that cardiomyopathy, one of the first subtle signs is increased heart rate without anything else. I mean, so that alone would be enough for you to work them up. So that was definitely reasonable.
Yeah, good clinical point, Doug. And I would agree. That's a case I would refer to Peds Card. So it's good that you've gotten them in already for assessment. Can you give us follow-up later? What you hear about that case, Sarah?
Yeah, definitely.
Okay. Anybody else with thoughts about the myocarditis concern? Mary Beth, did that answer your question?
Yes, I think most of these kids have a normal exam and we're not terribly concerned. And I think a lot of it is anxiety. We get a lot of kids calling with, various side effects that are probably more worried than anything else. But I'm just wondering how I can take a patient who I think is well and still reassure them by getting the appropriate workup, but without needing to send them to the emergency department and creating $1 million bill for them.
Yeah, I think if they're hemodynamically stable, clinically, I think you are okay to do that as an outpatient workup, whether you order the EKG or whether you refer them, to peds cardiology to do. And I think reserving, an ED or urgent, or a semi-emergent visit just for patients that really appear clinically unstable makes a lot of sense, Mary Beth. And that, in most of these cases, Eric Ingrowski, you just posted in the chat, I see that you had a college patient who did present with post-vaccine pericarditis. Did you want to comment about that one, about how that patient presented?
Sure. So it was interesting. His sister, who was a 17-year-old, got COVID in November. She came in about a week and a half into her COVID, complaining of shortness of breath and chest pain. And she ended up having a high pro-BNP. Her CRP and SED rate were way up. So we were worried about MIS-C, all kinds of stuff at that point. Ended up being seen by cardiology that day as an outpatient. They followed her as an outpatient. She did okay. He ended up getting COVID about 3.5 weeks later and did fine. And then he got his vaccines for COVID this past April. And it was 3 days after his second Moderna that he called us with extreme chest pain and difficulty breathing. We instructed him to go to the emergency room, and his troponin was up. He had myopericarditis, got admitted to Olean General. Really never did anything clinically in the hospital other than the pain and the abnormal labs. He never had any arrhythmias, never had any myocardial dysfunction per se, but put on colchicine, indomethacin, and discharged 2 days later. So he ended up a VAS report, but it's kind of interesting, 2 people in the same family with cardiac issues from COVID, one from vaccine, one from the actual infection.
Yeah, that is unusual. Anyone else? Thanks for sharing that, Eric, and Mary Beth, for your question. I wish I had George on the call today because I think he could answer even better, but I'm happy to, one thing I'm happy to do is just loop back around to him with an email, just sort of summarizing some of what you all shared, and Mary Beth, your question, and can share it back to you all in terms of urgency of workup, if that would be helpful. I could do that tomorrow and reach to George. I do want to say, I think Peds Cardiology has really stepped up in terms of their ability to see patients quickly with this, knowing that they had quite a wait list for cases before. They really transformed a lot of their outpatient care as a result of the pandemic. But I hope that you guys have been experiencing a positive turnaround and short wait time for visits. Okay. Anything with COVID vaccine? Anybody have any other comments about how it's going, how it's not going, questions you had for anybody else who's doing it?
LJ?
Going once?
Okay.
Yes.
So I'm just curious how the other practices are handling administering. We're just doing COVID clinics, but is anyone doing it point of care at physical exams?
Doug, you raised your hand.
We just give every opportunity we have. So I mean, I'm talking to parents at checkups. I say, have you had the vaccine yet? And the parent says, no, I haven't. And I said, well, why haven't you done it? Well, it's too busy at home. I can't get my child, no babysitter for my child. And I said, well, we could give you a vaccine today. And so we've got them. And then actually she called her husband is waiting in the car. So they waited a half hour, then they switched, and they came. So we're doing parents and kids during the day. We're wasting doses left and right, not a whole lot, but we're wasting. We keep some vials of J&J in the office too, if we need to do that. So we're giving to adolescent checkups. We're giving the vaccines too as well. And hopefully we try to get it within a 6-hour period. I'm trying to group our adolescents toward later in the day so we can get to the clinic as well. But every day I'm going on nicest and putting 1 or 2 doses wasted. And so far they haven't yelled at me. But I think we're doing the best we can, and it can't hurt to do well visits when you can.
Yeah, Doug, they're not going to yell at you. They are not going to yell at you for wasting a couple doses. This is huge. I mean, the whole vaccine effort has just done a complete shift at this point now. I think
transporting the vaccine, when we went down to the defreeze and refreeze, they said, oh, you have to call. But now we're using the angel couriers, as they call themselves now, to get it from the health department. So yeah, we'll get delivered to us.
Great.
Have our nurses go on to NICIS and download patients' vaccines ahead of time, So we can figure out who's already had the COVID vaccine, so we can estimate who may need it coming in that day. And what we found is like 80% on one day already had the vaccine. So we would have thawed bottles, put them out, got them all ready to go, and just wasted them if we hadn't done that. So that's been helpful.
Mary Beth or Janet, both of you are unmuted.
We just started our COVID vaccines in the office today. Had a couple, three with checkups that were pre-scheduled, and then one we knew was on the waiting list and called them, they came in. But again, just like Eric just said, we've looked on NICES and downloaded, gotten their shot records, and the vast majority of the kids have already had it, or the parents don't want it. So we're trying to figure out, are we going to need to do clinics? Should we just stick with doing a point of care or what? So we're sort of nascent, but we've started it now. So it's pretty well understanding.
Thank you, Janet. Any other comments from practices who are
No, other than
vaccinated?
LJ, for the people on Medit, I hope Eric and Janet and anybody else who's on Medit knows that it's two-way now. You can pull from NICES into Medit, so you don't actually have to go into NICES.
Yeah, we're aware. That's a great function.
Yeah. Yeah, I haven't figured out how to do that yet, but we're working on that. Maybe I'll pick your brain on that.
Yeah, I could send you an email.
Carol, once we send out through HP, give it to all the Med people, because I don't even know how to go back.
Yeah.
Okay, I could. LJ, can I send it to you and you'll send
That'd be
it
great. Thank you.
Okay.
I saw that Cindy Rand posted that they're getting a lot more vaccine refusal right now, and hesitancy in the population for also children's pediatric practice. And I think, with this kind of thing, I think it's just, even if you're not changing someone's mind or a parent's or a caregiver's mind in the moment about the vaccine, just having the conversation, them knowing that you are making it available and that you are giving it in the office also lends credibility to this for many people who have seen this as like, I have to go to a big central site and the National Guard is there. Like that freaks some people out a little bit about what is this really? And I do think that, it takes time. This is, the reason why a lot of you are seeing a number of kids were vaccinated is because those families were ready. They wanted their kids to be done straight away. But for the long run, really, for boosters and for getting those families that were hesitant to begin with, having it in your practices will make a huge, huge difference. And you guys, I just gonna say it because I can. Renee will back me up on this. Like the independent pediatric practices and some of the independent internal medicine practices have really led the way in this space. Demonstrating, working with the county, demonstrating it's doable. And I just am super proud. It's really fun to be in these meetings and have Renee say, well, she rattles off the huge number of pediatric practices and family medicine groups and internal medicine practices that are doing this already in the privately owned space. So great work. Really, really important. There's a couple of comments in the chat that I'm just trying to look at really quick. Janet's comment, we're mentioning to parents of younger kids that hopefully later in the year we'll be able to give it in the office to younger kids. Absolutely. Inside scoop on when the vaccine is going to be approved for younger kids. I do not have that inside scoop. I've heard all sorts of things. Before you were hearing it would be, in 2022. Now it sounds like people are saying maybe by some point in the fall or late fall. I don't think we know unless anybody else has an idea about that. And I just wanted to add one more thank you and kudos. Like Janet just mentioned that English Road Peds was, open. They let her come in and see how these clinics ran. Irondequoit Peds, English Road Peds, and then again, some of our adult medicine practices. You guys like really jumped in like way ahead of the game. And if I missed somebody else who did that jumping in ahead, I think Stony Brook Peds also actually was already doing this before we even had the chance to get other practices going, and the rest of you just jumped right in, like without really hesitating, and I think that's remarkable. One more comment in the chat. Oh, conflicting info about whether it can be given at the same time as other vaccines. That was an issue. It is no longer. an issue is my understanding. Anybody want to correct me on that? There was a concern about not having to have a 2-week window in between giving the COVID vaccine with other vaccines. That is no longer an issue, and that was a huge barrier to have removed. Yep, and for the CDC link, I'm putting it in the chat for those who would like to look at that to help with Sarah's question. Okay, change of topic. Back to school. So I would just love you, like, just unmute and go. I think I already can anticipate the topics that will come up, but what would you like to see worked on, thought through, new guidance if possible? Right, granted, we have to follow CDC guidance, but what advocacy to the state so that we're not scrambling with state guidance that is, I won't even say, just was super complicated to interpret and follow. What would you like to see? Somebody just messaged something in the chat with a big please. Yeah, back to school, get them back to school. Amen for that. Anyway, and I think through the kinds of the Finger Lakes, I think there's I've heard Mike Mendoza say we will be back, and but certainly has a commitment. Katie, I see
Yeah, and I know you guys have touched on this in the past, and I know it's like asking for a miracle, but I think the biggest thing that I've seen, even just in the last week, oh, of course, everyone's going to chime in at my house now, is, oh boy, let me see if I can run away, is children really just running into issues with using it now to get out of school. So kind of fine tuning the symptom list, which I know is probably never going to happen, but how every symptom under the sun is listed on what gets these kids out of school. And now you've got the teenagers going to the nurse saying, oh, I don't feel good. I need a COVID swab, knowing they're going to get out for a day or two. And sort of the struggle between being able to manage that idea of, doing the right thing for the community, but also not, manipulating the system. And trying to make that better. So working on that symptom list, and then the process for the testing. I don't know if you see that changing for September or how that's going to work. I mean, I get it, but I just feel like in so many different ways the system has failed and people are just kind of going rogue. And that even within our practice, the 9 providers, you see people trailing off, and it's just really hard to keep that consistency. And I didn't know if you saw any change in that coming down the road, or any talk of how that may change overall.
So those are 2 of the things that I thought would come up from the group. Absolutely. There's been a lot of talk about that. There was a lot of talk about the symptom screening, that exhaustive list of symptoms, as well as what is acceptable testing. And that's been, talked about test modalities. Rapid testing, does it have to be a deep NP swab, all of the stuff that we talked about during the pandemic. So there is what I can share with you is there is a small work group that is going to be meeting starting in the next 2 weeks that will actually be looking at data nationally as well as some local data around the symptoms that appear to be most consistently associated with COVID-19 infection. So I give a lot of credit to the Rochester regional team that have been doing some assessment, looking at, kind of the symptoms most correlated. Their numbers may not be high enough to be able to generalize, for like a validated tool, but that combined with work that's being done around the country may really help inform things as we go back in the fall. So I do hope we're coming back with a somewhat different list. It's still going to be relatively broad because, as you know, a kid can present looking like they have allergies or a cold and they can't have COVID. But there may be accompanying symptoms that make it more likely or less likely. So that's some of the stuff that's being looked at. And then I think the process for testing, we have asked for URMC labs to partner with Rochester Regional Labs and to do a deep dive assessment of all these different platforms, all these different testing things, so that we can really be giving the best possible advice to our primary care practitioners and to our school nurses about what to accept. You know, we have said that with everything being new during the pandemic, right? You know, PCR testing, the NP swab, gold standard when you have a patient who has symptoms of COVID, right? But there are some other platforms that look to be performing, you know, better now, and so we need a relook because the technology is changing as we've gone through this, and so we expect to be able to give out some more detailed information, so practices, you know, can inform what they're doing or what they're choosing to do in terms of point of care, and then also so that the nurses really know what to accept. So those are two things we will absolutely have, I think, new information in both. So I'm looking because there's a lot of stuff you guys have put in the chat. It's hard for me to talk and do that and listen. It's like doing 3 things at once. It's like being in my household with my kids. If parents have been vaccinated, the kids don't have to go home for minor symptoms would be a great incentive. Yeah, would be a great incentive. I don't know. Testing is haphazard. I agree with that, Janet. Can we tell school nurses to stop telling patients to go to, yes, urgent care for their COVID tests? You know what, Mary Beth, we put that out. That information has gone out multiple times to the schools and to the school nurses. And you know what? We can do it one more time. I will be with that schools reopening task force team tomorrow, no, Friday, and we'll ask. Usually these messages end up going out through the district superintendents to the administrative offices and the school health offices at the schools, so we can reemphasize that again. Because obviously you guys, many of you are doing the PCR test at this point. Any concern? Let's see. So so there's a question that was a direct message about whether COVID variants change over time. Will that change, you know, will that skew any data about the local symptom list? It's a great question. But so far, with the variants that have been there, we haven't seen any change in terms of symptom presentation. So I think that's something we'll need to watch for. And, you know, this is just like, this is all very much learning and studying as we go together. And I think not recognizing we don't have to look just at our own community, but looking at data across the country and other areas of the world too is valuable. Acute Kids is turning around the whole testing process in 1 hour. This is Corey Wert's comment versus the hospital systems, which is 24 hours. So I think it's important to recognize that Acute Kids is using a Cepheid platform that's not the same as the one utilized by the hospital system, but it is effective. I mean, it is a PCR platform. So I think that's the difference where you look at point of care. But I mean, that's really a choice for you all, I think, if you want to send your patients to an acute care center for a 24-hour thing versus like, no, right? You want them coming to you. That's what I would want. I don't know what we can do to change that. I don't see at this point, but we can ask if we anticipate that U of R will be turning around faster, but you figure there's transport time, right? And then it's the running of the test. So I don't think there's ever going to be a time that the hospital teams can do things, you know, that will be as fast as the urgent care centers. I think directing patients back to their primary care provider, which was Mary Beth's original comment, is probably the most important thing. Another comment about having protocols for a child who's been vaccinated, a child who has COVID, who needs testing. So at this point, whether or not you're vaccinated, if you have symptoms right now, you still need to be tested because you can still have COVID and you can spread that to others. So being vaccinated doesn't change anything about testing. What it does change is your need to quarantine if you're exposed to someone else with COVID, that you don't need to quarantine. We just reviewed all of that. So at this point in time right now, that's the current status with that. What does a test mean? Can whoever put that, I don't know the answer. I'm not reading the question right because I'm reading in front of you all getting anxious. This is Doug. Doug, can you explain? Right? Was it you?
Actually, it was me, Teresa.
Oh, Teresa, I'm sorry.
Hi, how are you? No, I think, because I think it's a sort of a school nurse kind of question too. So I think going into the fall, really having protocols, because I'm actually really astounded about, we've been doing this for, it seems like a million years already. And parents are like, what do you mean I have to quarantine 10 days and a negative test doesn't get me out of quarantine? So like, it's just, so when you're getting calls from these school nurses and they're like, oh, but the child is vaccinated. So sort of having those part of, we had great protocols about who gets sent home and what we need to do, sort of going into the fall, thinking about, okay, this kid is vaccinated, or this kid has had COVID in the past. What does that mean as far as, I just think it's an educational thing. And it also should be very protocolized so that everybody's on the same page. Like, okay, because my daughter is 15, she was in the Pfizer study. Fortunately, we just found out she was vaccinated in December, which is nice. But she's also now in the sub-study of looking at asymptomatic carriers having been vaccinated already. So I'm so excited that we're going to get that data at some point, because I feel like that's what we need partially. But so just going forward to be in the fall, everybody on board with, okay, this kid has had COVID. They had COVID in April, 90 days from there. What does that mean? Do we still PCR test them? Just sort of all of that stuff, sort of thinking through ahead of time. Because I feel like when we first started with COVID, so much of it was that processing and trying to figure out, where do we go from this and what do we do next? And okay, now it's 95 days. And so are your antibodies good or are they not? And I feel like that's going to be a big parental, type of complaint saying, oh, they've already had COVID. Why are you sending them home, in September because they have a runny nose or stuffy nose, but their, COVID was 6 months ago.
Yeah.
So I just think that communication, I think, would be helpful.
So a reboot on the protocols, especially looking at past COVID infection and vaccinated patients, as well as people who have not had either vaccine or COVID. And then I think making those, what I'm anticipating will happen because those sessions have worked pretty well, is there will be probably 2 large school healthcare combined meetings over the summer. One will be early in July or mid-July, and to really focus on behavioral health concerns for kids and to bring in a team to really just dive into that more. But then another one will happen in August, and the August one will be at least 2 to 3 weeks before school starts. It will be a deep dive into all of this, new protocols, what the revisions are, where we stand, and just making sure that that's available to schools and to primary care. Doug, I'm right with you, like patients who are getting results from drugstores, like the home tests and what that all means. It's going to become, if anything, where we think we'd be more organized and more coordinated, it feels like it's going to get even more chaotic, because you guys aren't necessarily going to know that a patient tested positive for COVID, and you've been able to do all the appropriate, anticipatory guidance for them around MISC or screening before, assessment before they go back to school.
And we even had a 17-year-old who came in for a toe injury and then said, oh, by the way, did you hear from CVS that I was COVID positive a month ago and I've been playing sports since, full, So no,
oh my God.
No, you think the parents would have some, you should trust that they'll call you, but there's got to be some, maybe when you talk to the school nurses, that could be hard to make, emphasize to parents that you need to communicate with your doctor so we can coordinate. That's
a really good point. I mean, even if that's sort of almost a checklist thing that is part of the, if a patient has tested positive, because there's no other way to track that. If that information doesn't come to you, you're not going to know. So I think we got a lot of work to do in this space, but what I would love to see is, people continuing to work together, not getting frustrated with it. We should be in a better space. And God, I really hope, to whoever asked the question about vaccine, was it Sarah who was asking the scoop on vaccine? I pray every day that we're able to start vaccinating those little kids by the end of the summer and early in the fall, because that would just be huge. We'll see. I don't know. That's my wish. What else have you got? Anything else you want to put on the table with 4 minutes remaining till we go, or should we just wish each other well and early I think that that's the right thing to do. I really just always appreciate you guys, appreciate that you're willing to come and hang out on a Zoom call at the end of a long day. We covered a bunch of stuff here today. Thank you for new folks who joined us and for the folks who have come back multiple times. I will follow up with you all. Mary Beth, I'll get that information about the post-COVID myocarditis. And then Carolyn, you'll share that information, right, about MedEnt and NISIS. And we'll make sure that you guys are notified when these next sessions are going to happen with the Return to Schools team. Otherwise, I wish you guys well. Enjoy the month of June and kids' activities again, because there's a lot more that's happening. Thank you, guys. We really appreciate you. Have a great night.
Good night, guys.